So good morning, everyone, and a warm welcome to our webinar series on quality controls and data management for medical labs. So the key focus of this webinar is to provide training and education around QC practices for diagnostic labs. So we can all appreciate that there are various wonderful tools and innovative solutions that can be adopted to enhance the way we do the QCs in our labs. So, and a key and centric component of the successful adoption is the people who utilize these tools. So that comes with a combination of your knowledge, the willingness to learn, and the right mindsets. So our goal and objective is to help all of us who count the people, because it is us who count the most in bringing about the change that will enhance how we do things in the lab. So overall, we all have a moral responsibility to serve our patients the best way possible and ensure their safety. Remember, we are all one step from becoming a patient, so it is not a one-off effort, but a continuous journey that we aim to continuously improve. So thank you for making the time to join, and we look forward to having a fruitful interaction. So a quick introduction to F&S. So we are a supplier of lab equipment and consumables, serving customers across different sectors, not only the clinical diagnostics, but also research labs, food quality, and also industries. So on the webinar today, we have our clinical diagnostics team, myself, Joyce, the sales and application specialist. Then we have Leah Wangoi, who will introduce herself. So I'll hand over the floor to them just for a brief introduction. So Leah, Eva.
Good morning. Evelyn Chepkoech, welcome to this webinar. Thank you.
Good morning, team. You are welcome for this webinar. My name is Leah Wangoi, Sales and Application. Welcome all.
Okay. On the call, we also have our channel partner, Bio-Rad. So I don't know, Fiona, if you can say hi, quick hi. I don't know if she's on mute, but in case we have a chance, I think she'll have a chance to say hi, hello. And then our speakers for today, Madam Jackie and Mr. Arnold. So just general housekeeping rules. Please keep your mics on mute so we don't have a lot of noise in the background. And then in case of any questions, please type them in the chat box. Yeah. So in this presentation, we'll also be running polls. So please feel free to participate so that we can be able to capture your thoughts. So an example of such a poll is what we're about to launch right now. So if you're able to, please have a look at it and give your responses. The poll shall be live. Okay, as that proceeds, I'd like now to hand this over to Mr. Robert Njuguna. He's the case officer from KENAS who will moderate the session moving forward. Welcome, Robert.
Hey, good morning, everyone. Good morning, our participants. I hope everyone can hear me very clearly. Welcome to this webinar hosted by F&S. And of course, the webinar is on quality control and data management for medical laboratories. And this session is going to run all the way up to Q1. Today, I'm going to be the one moderating this session. My name is Robert Njuguna. I think I'm no stranger to most of you. I work at Kenya Accreditation. I'm a trained assessor. I'm a trainer for QMS and for medical laboratory standards. And I do many other things as part of my primary responsibilities as KENAS. So for here, I'm here to make sure that we have delivered a very good webinar and the message is understood by all of you. So I will go straight to introduce our speakers. We have 3 speakers today. And the first speaker is going to be Jackline Agunda. Jackline Agunda, I'm very sure is no stranger to some of you, or most of you. She works at Aga Khan Hospital main laboratory in Nairobi, Parklands, as a quality advisor. And she has helped the Aga Khan Hospital laboratories to attain and maintain accreditation based on CAP, which is College of American Pathologists, ISO 15189 accreditation from SANAS, and also the hospital accreditation, that is the JCI, Joint Commission International. She has played a critical role in maintaining quality management system for those particular standards. Jackie is a medical laboratory professional with a BSc, and also she has an MSc in medical laboratory sciences from Nyagah. She also has other courses such as developing healthcare leaders for tomorrow's course that she has attained previously. Also leadership and management in healthcare at the University of Washington, and she is also have knowledge or is knowledgeable on quality and patient safety, and she is a guru in quality management system, as you can see. So, ladies and gentlemen, join me in welcoming Madam Jackline Agunda to this session. Jackie, over to you. Jackie, can you unmute?
Yeah, I was to unmute. It's only that I'm just doing the logistics of sharing the slides. Can everyone hear me?
Yes, all good.
Robert will have to answer so that I can. Okay. So today's topic, thank you so much, Robert, for that introduction. I feel honored. Basically, we will go through the comprehensive overview of quality assurance and the management concepts of quality management. Feel free to give your questions while we go on in the chat so that we don't interfere with the presentation. Part of my introduction I'll do about diagnostics, as our colleague has said. There's a lot of quality around, but basically we'll be dealing with diagnostics. What is QA and what is the difference between quality assurance and quality control? And the reason why we'll do basic introductions and maybe just defining some of these things, because I meant to understand that the team that is here, there we have pathologists, we have technologists, so that we go together. We need to make it fair and just so that everyone goes with us. So the difference between quality assurance and quality control, one, if you forget everything else, just know that QA is the process. You're bringing in everything else to make sure that you have a quality result in your pre-analytics, in your analytics, and in your post-analytics. So I have diagrammatically presented that in this slide. And from what you can see, when we are dealing with pre-analytics, we are doing everything else that pertains to the specimen that we are collecting. One such example, for example, if we are looking at urine specimen that is supposed to come for culture and sensitivity, and we bring in a contaminated specimen, basically you'll give that patient a report that is not for that patient. And for that case, you'll also interfere with the clinical management of this patient. So that diagrammatically present the same. Same to blood. If you give a sample that is not for the right purpose, it will not serve the purpose for diagnostics. One such example, if for instance, you get a sample, and this has happened before in our journey of quality, you find, let's say, because we deal sometimes with the clinical team, you find you want a blood culture, for example. And then because the clinical team was struggling to get the blood sample, I know some people will identify with this, and they remove an EDTA, which was already removed. Maybe they get a syringe and remove and put in the blood culture sample. And then you bring in for culture. Basically, one, you are likely to get a contamination. Two, you're likely to not get the right thing that you're looking for because this specific blood already has anticoagulants. So that is basically what we are talking about. And in terms of now testing, you look at how are you managing your tests in a quality way. You are doing quality control. If it's calibration, let's say in chemistry, you have done calibration. If it's on coagulation, let's say you have those that need calibration, you have done calibration and your results are out in the right way. So one thing we normally say is that your specimen is as good as the integrity, or your results are as good as the integrity of the specimen. So don't forget that. In terms of post-analytic, all this is now quality assurance. In terms of post-analytics, you need to ensure that the results that are being channeled out are the right results to the right patient. And how you do that is just details. The logistics of how you'll do it, you just ensure that quality is not compromised. What is the role of pre-analytics? As I have alluded, integrity of the specimen is equal to the quality of your results. If you get a wrong specimen, if you get it in the wrong tube, if you get it in the right, in the wrong, if it's underfilled, such example may be things like coagulation, because the ratio of anticoagulant to the specimen is very important when you're analyzing this specimen. So I have put there those several tubes so that you can just identify with them. Now, there are people, because I was also told there's a Uganda team. We don't know your logistics of how this happens. But even those who are in Kenya, there are those labs that really don't have resources. On a bare minimum, you just need to ensure that your specimen is in the right tube. If it's supposed to be in EDTA, it is in EDTA. For instance, if you need to do a test that needs serum and you find that you have an EDTA sample, you don't go getting plasma instead of serum. So very important, because the manufacturer has defined what is the bare minimum of what can happen. So those are some of the errors that we experience. I want to mention something about patient misidentification. This is the most common error that happens in most of the labs. And this can like start from the clinical side and reach to us in the lab. And you need to come up with a process of tracking some of these errors that happen in the lab. And that is the whole essence of quality management system. So once you get some of the errors, some of the issues that you think will interfere with specimen integrity, then you come up with the rejection criteria. How are you going to make sure that rejections are happening? You're not just rejecting because, again, quality is, if your team has not embraced quality, it's sometimes very difficult to even implement quality. There are people who will think that once you reject the sample, you have malice in it. And some people will identify with statements like, you guys, are you putting clots in this specimen? No. Specimen integrity, as I've mentioned before, is equal to quality result. So the rejection criteria is very important. Reject those specimens that are not of integrity, and then you can do a recollection. And some of them will even tell you, for people who have inpatients, for small babies, they'll tell you this baby is so small, please just run this specimen on this sample, the test on this sample, because you're not able to get another sample. You will not be helping that patient. In terms of quality control, you need to get the right QC, and you also need to establish the acceptable ranges for this control material, and that is when you have now received the new method. People who work in chemistry, they really understand the bullet 3, that we need to have applicable rules in interpreting changes in the diagnostic cycle. Hematology may not have a lot of Westgard rules, and my colleague will be presenting in terms of Westgard rules. But chemistry, they use a lot of Westgard rules. And I think at this point, that is where Bio-Rad comes in. I know they have not hired me to talk in terms of them. They have not told me to market them in this webinar. But this is the reason I mentioned Bio-Rad is because this is what we use as Aga Khan Hospital in terms of chemistry. And we're also planning to expand it to people like hematology and any lab practice that is using quantitative analysis. So what are some of the types? I was just trying to see, because of the time, to not mention almost everything, but just to help us deal with what are we dealing with in terms of quality. So when you come to types of quality control, we have those quality control that they'll have a multi-analyte inside them. A vial will have more than one analyte inside. As you perform them, you will be evaluating very many analytes in that control. The opposite of that is, I don't know if you'll call it unilite or something, but it has only one analyte inside. For instance, if I am doing ESR, I'm only concentrating on ESR. A multi-control will be, I have, for instance, if I have immunoassays, for instance, it is one control that is captured inside one vial of controls. One other type is qualitative. Qualitative is where you have one control, for instance, is just telling you whether it's negative or positive. Such example would be maybe if we speak in terms of Bio-Rad, again, and F&S, we will say controls that they are using for blood group, something like that. Just say if it's there or not there. You're not giving any value to it. You're not saying it's 10. You're not saying it's 20. You're just saying it's there, it's present, it's absent. And you're also saying it's negative, it's positive. That is what we mean. What is the importance of doing a QC, quality control? Remember, I defined quality assurance as a system. Now, QC is what, like what you're using to just check if, for instance, I ran a sample to determine if this equipment has errors. This personnel has, because when you're running a QC, we are checking on the equipment, we are checking on personnel, we are checking on the reagents. That is what we mean. So in just basic language, that is what it means. It's different from quality assurance. Quality assurance is the bigger mother of QC now. You're doing the whole thing to make sure that you have quality assurance. But quality control is that aspect that you're doing to control it. We can call it corrective, while we can say quality assurance is preventive, because it's the whole system. You just make sure that you don't have errors in the pre-analytic, analytic, and post-analytic. So I've mentioned there some of the importance of QC. When we say meets regulatory and accreditation requirements, some of you may not be accredited, but when you get accredited, each accreditation, they have their own requirements, and they'll give you a checklist. And some of them will be prescriptive. For instance, you are accredited for CAP and SANAS. So SANAS may really not be prescriptive, but CAP will be prescriptive. They'll even tell you what they expect you to do with this QC. They'll define how many they expect you to do. In case you're doing coagulation, in case you're doing microbiology, they will expect that in histology, you do quality control for your, let's say, the word has gone. But in histology, you'll have to do for I'll remember while we go. So it will also help you in terms of laboratory reputation. How do we get laboratory reputation? Once you make errors, our clients nowadays are not silly, and they read a lot and they know a lot, including those small labs. They'll tell you this result is good, this result is bad. They'll tell you, I came to this lab and I was given a diagnosis, but this diagnosis was not the right one. With all this, you'll also build trust with your patients, your clients, and even the healthcare providers. And I believe I'm not bragging, but some of this is what has made us as Aga Khan get to the map to where we are. So we don't just run results. Once the patient, the control does not pass, then you don't, histology, I meant surgical cases and cytology cases. So you don't just build trust in a day, but us as an institution, we don't run tests if QC has not passed. We rather outsource, and that is an expensive venture, believe me, but we rather outsource if everything else is not working for this specific equipment, rather than running a result that we are really doubting the integrity of the equipment and the whole process. So another thing is that it will reduce the cost of retesting. If you have to retest, if your QC passes, basically you'll not be doing retesting because maybe a patient has complained or something like that. Something that I didn't put here is in terms of litigations. Remember what I've just mentioned? Patients will even take you to court if they find out that your result was not correct, because patients will go and even repeat it somewhere else. QC will really save you on the same. And even the whole aspect of having quality management system. So what is the objective? First, we want to detect and minimize the errors that we have in the laboratory. Believe me, every lab is prone to errors. So every lab should be striving to make sure that the errors that we produce are minimized. So once we identify them, those that will be affecting our patient safety, we really need to reduce them and even remove some of the errors, because patient safety is key. And I will tell you this. For example, if you do a test for a patient and tell the patient that your HB is, let's say, 5, basically the doctor is going to give this patient, try to request for blood. If they don't request for blood, maybe it's a chronic issue, they'll start giving the patient hematinics. You see, patient care has already changed because of the lab that has done these diagnostics. So it's very important to make sure that your lab is using QCs, if it's calibration, if it's anything to do with quality control, so that your results can be of integrity. So test results, again, that is what I have mentioned, and that your results are also reliable and precise. What do you mean by precise and accuracy? Precision is just when you run this test today and you run the same day, let's say, for example, the same patient is requested for that same test the same day. The difference should be very minimal. So that report is precise. For accuracy, you're just trying to compare it to the standard. Like if I compare my results to a standard that is really set, is it close to that standard? And for that eyeball I have given you, that explains it all. So again, I had given here some photos, some pictures. I wanted to be a bit unfair for F&S because some of these I took from their website, because they're the ones who have organized the webinar, yeah. And it allows me to be biased because it is their webinar. So some of the examples they have is some of the controls that we have, specific examples, those controls that we have human-based matrices, and they're like for the first photo. And some of the other specific examples is where you have lyophilized quality control. Most people prefer lyophilized because one, they have longer expiries and they don't really like misbehave so much. I'm not saying liquid quality is not good, but in terms of I don't know if I should use their hardy or something like that. Lyophilized controls are good, where you have to dilute them before you run. But liquid controls, you already pre-diluted, so you just analyze as they have come. Most people, like for instance, those that they supply for us, we will dilute and then freeze or keep them in a temperature that will take them a bit longer before they expire. So why did I put ATCC there? Because this is American cultures that we use for quality control. This is acceptable as per our accreditation standards. Yours may be different. This is for microbiology when they are trying to control their cultures. That is one example that I gave. This is for qualitative. The rest, the top one here and this one, liquid lyophilized, may be quantitative. I had also shared the IntelliQ load, and this is also from Bio-Rad. These are whole blood, and they are used for things like blood bank. So how do you select your QC? You select your QC by, and my colleague will talk about the rules and Westguard and everything else. That is one area you also look at. You also look at the matrix. QC should mimic your patient samples. Most manufacturers will actually mimic the patient samples. That is one area that you don't struggle with because most of the manufacturers have really set that for you. When I say clinical decision range, when you have your analytical measurable range, and I mean because we may have people who have not been so much in quality, is that once your instrument is supposed to be linear up to this level, you want to capture, sometimes you may not capture everything. You want to capture the biggest range. You want to capture it on the lowest range. You want to capture it on the highest range. For example, if you are doing, I wanted to get a real example. If you are doing chemistry test that has an analytical range of, let's say, 10 to 1,000. I'm just giving an example. 10 to 1,000. You want to do your quality, like your QC should capture around that 10 minus and your 1,000 plus, so that you capture what you're dealing with. Again, you may find in the market you're not getting controls that are capturing your analytical measurable range or your clinical decision range. That means you can do a small validation and see from our population, for example, in Aga Khan. Have we had patients who this QC, they have gone even out of our analytical measurable range, and manufacturers will guide you. The standards will guide you on how to deal with that. So when you're choosing that, those are some of the things that you look at. So when I talk about resource allocation, is that you cannot be Aga Khan, and you cannot be Kenyatta, or you cannot be Gertrude's, or you cannot be that other lab in the rural area. You do what you can afford. You don't say, because in the webinar we learned that QC has to be done and we need to do clinical decision range or whatever. We must do this and ABCD. Do the minimum, because some resources may not allow. So for example, if you are not able to run 3 controls in a row, again, some standards will allow. As long as you have done on the lower side and on the higher side, you have controlled your system. So when resources allow, please make sure that you do You choose your QCs again. You don't go for the very expensive. You don't say we must get Bio-Rad when you can get this, or you must get Roche when you can get this, or you must get Sysmex when you can get this. I'm just giving examples. So if accreditation requirement has indicated, then again, I have told us that some standards will be prescriptive, some standards will not. So if they have required that you do it, and accreditation is very expensive, so once you decide that you're going for accreditation, these are some of the things that you factor in. You also need to look at the stability of that QC. Because some QC, if you brought a QC, for example, there are some blood bank QCs that expire so short, and there are people here who will identify with that. They have a 1 month stability. There are those QCs that have, even as I mentioned, lyophilized and those others, they have like 6 months. So you choose wisely. That is the criteria. What are some of the key elements of quality assurance? And this slide was supposed to appear before the other one. So as I have mentioned about quality control, that was basically internal quality control. So you also need to do some equipment calibrations. I just mentioned few, but in terms of quality, after you have done calibration, you also need to verify your calibration. What happens to us as an institution is that we have enrolled in CAP and we get that material to do our verification. It is called CVL. CVL is calibration, verification, and linearity. So for external quality control, some people will call it proficiency testing, and some people will call it EQA, some people will call it interlab, or even alternative assessment. What are we trying to do? You're measuring yourself to the standards of the rest. And while you're choosing the EQA provider, you also want to know how many people are enrolled in it, because you may be testing yourself against yourself. Very important. You also need to do your standard operating procedures. You write them. This guides everyone on how they should be doing their operations. If you're running QC, you need to know, how am I running this QC? How am I reviewing it? How am I validating this process and making sure that it's okay? So method validation is when the new equipment has come in and you do your method validation. This, again, you can use several ways of validating your equipment, comparing, again, doing accuracy, doing precision, and then checking what is your analytical measurable range by doing your linearity. There are very many resources that you can use for this, and read wide. You'll find yourself doing a lot of excellent job. Competency assessment, you need to make sure that your staff, as much as they came in qualified, they are trained and deemed competent, and you continue doing the competency. You don't stop at the first competency that you did. The reagents that you receive, every reagent, once they come in, if it's a new lot, you actually verify. And sometimes when you're doing QC, you find QC is failing not because the lot is different, but maybe how these reagents were kept. They were not kept properly. So those are some of the things that happen. So PPM is preventive, planned preventive maintenance of the equipments. You make sure that your equipments are maintained well. We are lucky, we have a department that does PPM for us. And apart from that, even if it's an equipment, main equipment, let's say from F&S, let's say Bio-Rad, Bio-Rad will maintain the equipment for you. You have a contract on the same, so that they can be coming in. They have to put that as a schedule, and they'll know that maybe they are supposed to maintain this equipment once a year or 2 times a year as per the manufacturer. And again, if the work is too much, then you even increase the maintenance so that your equipment can be efficient. I have mentioned about staff training and competency. What are some of the concepts in terms of quality control? Once your control has failed, you raise something called corrective action. And it's also important that you do preventive action. As much as you have corrected the error, you need to look at what is going to prevent future recurrence. This can be done in several ways. There's a slide that I have presented in terms of the fishbone. that can either lie under CAPA or under root cause analysis. So root cause analysis, you're just trying to look what is the cause of this mess, and you can use the WISE, you can also use the fishbone. All these things, if you're not so much used to them, you can just go find out from the resources that we will have given, and also just Googling around. It will give you a lot of information. So you also need to look at your reagent inventory. This is reagent management. All these things I'm mentioning here, they are under the 12 quality system essentials, but I have broken them down for our understanding. So the reagent inventory, you need to, as we have mentioned, you receive a reagent, you make sure that this reagent is okay. The first reagent that comes in is the first to go out if the lot is expiring before the other one. And if you do a very good reagent inventory management, then you'll find that you don't have reagents expiring on you. You'll also do a lot of saving. Customer satisfaction may not look like you really want to talk to your customers and find out, but it's a very big success to your institution. So find out what is the feedback from your clients. Then do the quality audits. You can schedule at least once a year or twice a year. Do quality audits. Find out, you don't need to be a quality manager to do these quality audits. You can do quality audits even on your own. Just find out how are we doing in terms of quality management. Do benchmarking, come to us. We are willing to offer you benchmarking. You go to other institutions, we are not saying we are the best. Do benchmarking, see what happens with other people in terms of quality. Then if you find out that there's something that you need to improve on, then do continuous improvement projects. Automation. I want to mention Unity because this is a Bio-Rad tool that has come from F&S. Why am I saying it has brought efficiency? Once we analyze the QC, and again, resources here allow, you have the desktops, you have your laptops, and from the equipment directly to the system, you are able to review and see what has happened to this QC. If the staff did not review, you will see. And if the staff is the one who is checking, they'll also see this is a failure and we need to review. Now, review does not just mean looking at it. You will actually put in that system the measures that you have put in place for the QC that failed. It does not, like it really helps you not to be having a lot of paper around, going to every time opening papers, trying to review LJs. Why am I talking about real-time Unity? Because it's the one that we have. There are very many on the market, but I cannot talk about what I don't have. So we have Unity, and we can say this has been an efficient business. QC basics, I know my colleague will talk about Westguard, but I just put this formula for you to know. For those who do not have a lot to do in their areas, I think there's someone making a bit of noise. For those who do not have a lot to do and they can just do these calculations manually, beautifully, technology has helped us. You can just go to Google and ask for SD calculator or CV calculator. Then you find how are you doing. CV helps us to calculate our not accuracy, but our precision, your reproducibility. You can also use your SD just to find out how am I deviating from my mean. So yes, this helps. And from what I have said, that when you're doing your some of the insights that we have for quality control, when you're doing your root cause analysis and when you're doing your corrective action and preventive action, it's good that you look at our processes. So you look at your equipment. You also look at, when I mention management there, I mean man, that is person, and how is it a process problem? Is it a human problem? Is it an environment problem? Maybe the temperatures are too high, the humidity is too high, the equipment is now becoming problematic because the temperatures are too high. I will tell you this from our experience because humidity can really also affect your tests. Remember, in Africa, most of these equipments were not manufactured here. They were manufactured Europe, Japan, or those kind of places. Those places are very cold. So again, it's important that you monitor your humidity. You monitor your temperature. The material that you are brought, is it reagents? What is happening with the reagents? Has it changed the lot? Or did we even do lot to lot in the first place? So you do all this and find out what is the problem, and then you do a preventive action. What will we do to prevent this problem? I have simplified that so that everyone else can go with us. Preventive action again, we can do risk assessment. By preventive, I mean you come in even before the problem occurs. So risk assessment is a whole topic on its own. We cannot even finish it today. But one thing I will tell you is this. You look at some of the risks that you have. And there are very many risks in the lab, including even pre-analytics. You look at the whole system. You look at the pre-analytics, you look at the analytics, and you look at the post-analytics. There are very many risks that we have. Look at the mitigations, some of the controls that you want to put in place. And after the controls are put in place, you look at your residual risk. Residual is that final risk now that you're looking at after everything else is done. Review your risks. Don't just put risk matrix. Review your risks at least once a year. Look at what you not necessarily once, but that can be a minimum. What can we do? We did this, but this is still there as a risk. You can also do EEMEA. This most likely in our place has been under blood bank. You do your failure modes and defect analysis. Sit as a team. Don't do it alone. Sit as a team. Deliberate. So what are some of the risks that you have here? How can we mitigate them? What are some of the controls that we can put in place? You monitor your quality management system. You come up with quality indicators. I just gave few. They can be many. You can do an audit and find you have other key indicators that you want to start monitoring. And once you see your performance is good, you drop it and pick another one. Don't have 1,000, don't have 100. Just do what you can manage. You can have even just 2. Monitor. There are those that will be standing like EQA because you're continuously doing it. You can consistently be having it. So again, it is your lab that will define and yourself define what you want to monitor as quality indicators. If you ask me, unless there is any question, my presentation is done. That is some of the reference that we have. You can look at it. You can go, sorry. Yes, you can go find out more about the resources that we have so that you even learn more.
Okay,
Yes.
thank you very much, Speaker Jackie, for a wonderful presentation. Okay, go ahead, Jackie.
Yeah, I think I have finished, and unless there is any question, I think I am good to go.
Okay, thank you very much.
I hope I didn't go out of my time. I was trying to just rush through. Thank you.
Okay, very well. You are within your time, and this was a wonderful presentation. I think you have even given more than was expected for our short presentation. Really appreciated. So we are requesting the participants who have the questions to type them on the chat. And as you do that, we are also running a poll. Please check out our poll again and participate. So should we have any questions, we have our presenter to respond to them just before we go to our second presenter. Okay. We have one question, Jackie. Okay, this participant is Kevin Ongaro. He's asking, my question is about running all three controls. In case of financial constraints, is it proper to run a normal control only? Can you get me, Jackie?
I was very specific when I said in terms of accreditations. And again, capturing the whole analytical measurable range. And this person, as they ask that question, I want to believe that you may not have resources, but it's good to analyze a control, at least to check. Now, when you do a normal control, yeah, you will only be working with normal people. But again, it's good to do something than not do anything. But when you're accredited, I'm assuming you're not. When you're accredited, you will not have captured the clinical decision panel. There are people who will be abnormal in your area in your area of testing. There are people who will be normal. So it's good to do a normal and an abnormal. But again, if you really are not accredited and at least you must do something, then please go ahead and do at least even a normal control. Just check your system. I hope I've answered your question.
Okay, I think that was very clear. She has told us that your QC has to cover your measurement range and what is important for the patient. I think that was very clear. There is a question, another question someone is asking Jackie if she can share the presentation. That is one. Remember, we cannot share the presentation without the consent from the presenter. And number two, someone asked, please give examples of benchmarking. Sorry? Okay, Jackie, maybe you can go on the first one as yeah, the two questions.
So I will start. The first question, Robert, was what?
They want to know if you can give consent to share the slides. The presentation.
Yes, I am not mean. These are my personal presentation. But if you really want it just to know how it goes, I have shared PDF with the F&S. Please feel free to share that presentation with the team. The PDF that I shared was not comprehensive, but 1, 2, 3 things may be missing there, but it will help. Question number 2, examples of benchmarking. Again, people will define it differently. Benchmarking will be maybe there are people who will define it like you come and see what I do, then you do what I do or emulate what I do. And then there are those definitions where benchmarking, they may actually mean that you send like an interlab. You send your specimen to us, we do, you also do, and then we compare the results. That is another area where we can do benchmarking. Over to you, Robert.
Thank you, Jackie. Maybe this is not a question. No, there is one more question. There are scenarios where there are no QCs in the market. What alternatives are there to continue testing? Someone is asking for alternatives when you don't have a proper QC in the market.
A very good question, Robert. There is something called alternative assessment. Even EQA, you may not have an EQA program with yourself. So EQA, when we talk about alternative testing, we mean you get a minimum of at least 3 labs. You do your test, you do the other person does the test, then you compare your results. The other option is just split testing. Like, for example, I split my samples among blind, it's also called blind testing, among technologies that are analyzing this test, and then they all do that test, and then we look at them. Sometimes it's tricky in some areas. You need expert opinion on the same. And those are 2 that I can give. And Sorry, yes, those are two that I can give in terms of EQA. And so alternative assessment in terms of IQC, that is now internal quality control, specimen samples from patients can also suffice. You get, let's say, a patient that had malaria positive, and you run that test again as your QC, it can suffice. If you have EQA, external quality assurance material, those are certified ones, you use them as your QC when you're doing the test at that point. It can also suffice. Feel free to do patient testing. You're using patient samples, but when you do patient samples, there is also a formula for the same. You compare what is the acceptable, if it's quantitative, what is the acceptable value, acceptable TEA, let's say TEA, total allowable error, that you'll get from Westgard. I don't know if my colleague will mention the same, but let me just mention that when you get total allowable error, you can go to Google and just Google. For example, if you're doing, let's say, I'm just giving an example, troponin. They'll give you what is the total allowable error for troponin. So once you compare the two, plus or minus, it will give you a value that you'll use to measure if you're within or not within. If you don't find that test in Westgard, then Data Innovations will also give you the same. I hope I've answered your question.
Thank you. Thank you. There's one hand up from Fred. Fred, you can speak. Okay, as Fred organizes to speak, Jackie, you can respond to another question here that asks whether, if you don't have QC, appropriate QC, if it is enough to run background check.
No, background check does not give you QC. You're just trying, you're just trying to see if your background is okay. As I've given you the options that you can use for your QC patient samples, and then you do TEA, please. Background check is just telling you that we do not have anything like that are really interfering with your testing.
Okay, another question, Jackie, if for the LJ charts, do you rely on the ones plotted on the machine, or you can plot yours?
Levy-Jennings? No one, and I don't think there's any standard that has specifically defined that you must get equipment to give you LJs. But as you do your LJs, be very careful that you can do an Excel. You can also, there are softwares that are in place to just help you do LJs. You don't need manufacturer LJs that are already predefined. So you can do yours, but if the manufacturer has given you the LJs, you don't go changing and doing your own. In accreditation, what we do is in terms of quality, not just necessarily accreditation, what manufacturer has defined stands. If you want to change what the manufacturer has done, then you do a validation for the same. Because the instrument you're using belongs to the manufacturer and they have tested it in the environments they know how. So if you want to change, you change with a validation. If the manufacturer has not given you the LJs, please plot yours. Plot on Excel and all the rest. I think next time we will see how to plot LJs. If F&S will call me again.
Thank you, Jackie. I think our next speaker will delve a little bit more on the LJs. I think I saw that. And there are now some questions here that have been asked. I will let you, the two of you, to respond to them after the second speaker, because they are basically about LJ charge. For example, one is about asking about how many pieces do we expect to fail, that kind of thing. So Jackie, we are asking you to remain until the end of the session, because there might be other questions that you may be required to respond. Is that okay?
I will. I don't know if I received from a participant about order of draw, or I can mention this once you guys are done.
No, okay, fine. Yeah, I needed to ask you to also shed some light on, you told us that your quality, the results are as good as the quality of the sample. Maybe you
Yes.
can talk something
I
to
will.
do with the order of draw, whether it's
Let
actually affected.
me mention that in passing. And order of draw, as I've said, integrity of your sample is equal to quality of your results. If you have to remove several samples with you, and you have blood culture, you have citrate tube, you have the plain one, sometimes with the gel separator, and then you have your heparin, and then you have EDTA, and then you have fluoride. I'm assuming you have all these tubes. If you don't have one in the middle, please just remove it. Now, your order of draw goes like this. You start with blood culture because of sterility and contamination. And then you do your citrate, your light blue. Citrate is your light blue, which goes for coagulation or all the related tests. Then you'll do your plain tube, and your plain tube can be with a separator or without a separator. And then you'll do your heparin, and then your EDTA, which is purple top, and then your fluoride tube. That is the order of draw. That is the standard of that is given.
Thank you, Jackie. One last from Fred. Fred, are you ready now to ask your question?
Maybe his mic has issues.
Okay, good.
Request him to chat. We can answer at the end.
Thank you very much, Jackie. Do stay with us until the other presenters are presented, because there will be a number of questions I see that you will still be required to respond to at that time. Thank you very much. Now, we're going to our second speaker, and the second speaker is going to tackle implementation of good IQC practices in relation to IQC ISO 15189 requirements and risk management. Of course, highlighting the changes with regard to QC. That is the changes in the new standard with respect to QC. So specifically, he will give us some insight on control charts, Westgard rules. That is why I said that the questions on Westgard rules will pack them until the second speaker finishes. Troubleshooting, the main sources of errors at the analytical stage. And he's also going to talk about the use of analytical goals in the clinical laboratory. And lastly, he will talk to us about customer testimonials with Unity software. Now, who is our second speaker? Our second speaker is Mr. Arnold Nyagah. Arnold Nyagah is a practicing medical laboratory officer with over a decade and a half of experience in quality assurance for both hospital and standalone medical laboratories. He is currently working with Metropolis Healthcare Limited as a quality assurance manager and also international business. He is also a medical laboratory technical assessor for ISO 15189. That one I can vouch for him. I've worked with him as an assessor, and he's actually a very good assessor for technical requirements of ISO 15189. So he's an assessor for KENAS. He has done over 20 assessments in the last 5 years, and specifically on areas of hematology, coagulation, immunology, clinical chemistry, serology, microbiology, and molecular biology. So he's an all-rounder. He is very well versed in all the technical areas of medical laboratories. He has a Bachelor's of Science in Medical Laboratory Sciences from Kenyatta University, and a Master's of Business Administration, Operations Management, and Quality Management from University of Nairobi. He is a member of Medical Laboratory Technicians and Technologists Board, and also the Association of Medical Laboratory Officers. So welcome, Nyagah. Please take us through your presentation. We will, of course, be waiting for you to respond to a number of questions that are already on the chat. Thank you and welcome. Is it Nyagah? Can you hear us?
Okay, thank you very much, Robert, for the precise introduction. Okay, and thank you very much, Jackie, for the elaborate QC practices presentation. Now, I would like to share my screen right away. Can you see my screen?
Yes, and yes, we can see it now.
Okay, let me put it in full screen now. Okay, so basically today I'm going to look at to give a user experience on how the Unity real-time software has managed to help us as a laboratory to navigate through implementation of ISO 15189-2022 standard. Okay, so my presentation will basically be in two parts. One will be we'll be looking at ISO 15189-2022 IQC requirements, and then we'll have some additional information on other requirements that are in the standard that are not in the clause for internal quality control that will require you to have some IQC data collection, analysis and review and approval, and how the Unity real-time has assisted us to be able to demonstrate these to our assessors. Okay, so the main clauses we'll be looking at in this presentation will be the clause 7.3.7.2 on internal quality control. That will be our main area. Then we look at the other requirements whereby IQC data will be required. Okay. So we'll start by on the clause for ensuring validity of examination results. That is, this clause mentions that you should have a procedure for you to be able to monitor the validity of your IQC, the validity of your results. So this one will encompass everything. That is your internal quality control and external quality control. So in this instance, what have we done? Okay, we've ensured that we get a provider who gives you guidelines on how to use and interpret QC data. Like in this case for Bio-Rad, they have procedures on how to use their softwares and also the products that they have. So we get an easy time to be able to get this. Then it also ensures that your data should be recorded in a manner that can be able to demonstrate trends and shifts. Okay, and also you should have some statistical techniques. Okay, that are to be applied especially for quantitative tests. So when you use software, it will be easy for you to be able to demonstrate the statistical techniques and also to be able to demonstrate your trends and shifts. Then this one also clause mentions that you should monitor these QC data, okay, and this monitoring should be planned and reviewed. Okay, so when you have a software, it's very easy for you to be able to generate reports that can be easily monitored periodically, depending on the specific period that you want to monitor and review. So this is the general requirements in this clause. So then we go now to the requirements for IQC, which is clause 7.2. And this clause has several aspects. And I'll go with the aspect, first of all, on the requirement of the standard on what the IQC procedure should have. Okay. Okay. First of all, is the IQC procedure shall ensure that intended clinical application shall be considered. Okay. In this case, if you're having a test like urea, okay. Okay. So if you're having a test that you have, that test has the intended use from the manufacturer. Once you check the key T-cert for these tests, you will be able to see the intended use. Okay, you will also be able to see the performance characteristics, the analytical measurement range, and this one. Now you should be able to use these key T-certs, okay, and the performance characteristics, okay, to be able to determine your IQC procedure, okay. You can also use global and local guidelines, CLEAR, EFLM, RICOS et al., to be able to determine the allowable errors, okay, and we'll be looking deeper into that as we go. Allowable errors that are there, all these standards can be able to be used, okay. Then the same, on the same IQC procedure, you should be able to ensure that you can, it should allow the detection of either lot to lot or calibrator variation or both, okay? So once you use, what we've realized is we are able to record changes in reagent and calibrator using this software, and you can be able to get a reagent lot, you can be able to get a reagent lot summary report, and you can be able to get calibrator lot summary reports, okay? Then you can also be able to get a lot changes which can be documented by the staff, okay, in supervisor's reports. We will look more into that. Then the IQC procedure should have, shall ensure that the use of third-party control as an alternative or in addition to materials supplied by reagent by the manufacturer of the reagent or the instrument, okay? And these third-party controls, some of them are Bio-Rad controls, okay, which we use consistently, okay, because they have several advantages that I'm going to show you, okay. Then there is a note that on that requirement for IQC procedure, it tells you about regular peer review is advised to monitor interpretations and opinions, okay? So with when you're having a third-party controls, it's very easy for your data to be peer reviewed because you get into peer reviews where you can be able to peer review against within your labs if you have many labs, or you can peer review within the method you're using or the instrument group that you're using, okay? So this one, one thing that we are able to demonstrate here. So a note is usually an extra item that the lab can adopt so as to implement a better QMS, and we've been able to get a solution to this. So on the other requirement on IQC is the IQC material shall have 4 things, okay? One of them is it has to be stable with regard to properties of interest, okay? And so the stability, you can get this from the kit insert, how stable it is, the material that you are procuring. Then it has to have a matrix as close as possible to patient sample, okay? So I believe my colleague has talked about the matrix bit in detail. Then it has to react to the examination method in a manner as close as possible to patient sample, okay? So you need to check with your peers. If you are having a third-party control, it's easier for you to check with your peers whether the control is reacting appropriately with your method, okay? And then it should provide clinically relevant challenges, okay? So basically check the controls if they are giving you pathological and non-pathological controls for you to be able to monitor both the pathological and non-pathological states of your measurements. Then another thing is this one now in the standard, the IQC part 6 says, if appropriate IQC material is not available, what you need to do is you can consider use of other methods, okay? Maybe trend analysis of patient results, that is the average of normals, mostly for hematology analyzers. Then you can do scheduled interlaboratory comparison, Okay, that is maybe using alternative procedure, and this now the alternative procedure must be validated for intended use. So if you are doing interlab comparison, kindly ensure that the lab that you're doing interlab comparison with has calibration traceability. Okay, and then you can also do retesting of retained patient samples. You can do delta checks. Okay, you can do normal range checks, and also you can do correlation with other tests. These are alternative, but these ones are only if there are no commercially available controls. Okay. Now, the part D of this says that the tests have to be performed at a frequency that is based on stability and robustness of your examination method. Okay, whether it is 2 controls per day, 2 controls per run. Okay, you need to check the stability and robustness of your examination method. And how do you check the stability and robustness of your examination method? This one you can check it easily by the review of your coefficient of variation and checking for your measurement of uncertainty, and also for checking for your total error. Okay, and in this case, how unitary time has assisted us is we can be able to have LJs and bar charts and measurement of uncertainty reports. Okay, which give us all the details that we require, and also give us a total error report, so that we can be able to see whether we are within whether we need to increase our QC frequency or reduce our QC frequency for that particular analyte at that particular moment. Then the clause on IQC still goes ahead and recommends that IQC data shall be recorded in a manner trends and shifts are detectable. Okay, so here, like you've seen there in the previous chart, you can be able to record, you can be able to see trends if they are there. Okay, if there are any shifts. Okay, and in case of any trends and shifts, okay, you can be able to detect that. Then it also goes ahead and says that where applicable, statistical techniques shall be applied to review results and especially test with quantitative components. Okay, where you can be able to maybe calculate the mean, your standard deviation, your coefficient of variation, measurement uncertainty. So all these are available as it's been easy for us to be able to calculate all these. And also, as you can see here, there is a variety of Westgard rules that are available in this particular software, and you just need to activate which ones will be a rejection rule. Okay, which one will be a warning for you. Okay, so that when it flags for you that there is an outlier, you need to take necessary action. Then the requirements also go ahead and tell us that IQC shall be reviewed, okay, within a defined acceptability criteria, okay, and also at regular intervals, and also in a time frame that allows meaningful indication of current performance. So in our case, how have we been able to demonstrate to our assessors that we are able to fulfill this clause? For defined acceptability criteria, there are total allowable error and also other guidelines that are available, whereby we map depending on the intended use of these tests. Then also we have regular intervals. Okay, we have we have some recommendations in our procedures, whereby, and also the standard recommends some instances where you need to do your where you need to review, okay, especially post reagent pack change, okay, and also post maintenance, major maintenance, post calibration, okay, and the other ones you can define according to the risk of that patient, of that test, okay. Then in a time frame, so in these, once you define the time frame for review, okay, you can be able to generate various reports How this Unity real-time has assisted us in this instance is while doing our processes, we've defined them that no tests shall be sent for approval without a scientific officer review, okay? And again, we've defined that no test shall be approved by this, no test shall be approved without the supervisor reviewing the IQC for that particular test. So we are able to do this in Unity real time, okay? Very easily, and because access is easily available for these to all the people. And then there is also traceability of the person who has performed each and every action, so it becomes easy to monitor whether the right person did what they were supposed to do. Okay, then the other requirement is when IQC fails to fulfill the defined acceptability criteria, the results are likely to contain clinically significant errors. The lab, okay, first you will reject, okay, and then you review, okay. What this software has done for us, once we've set the acceptability criteria, the first thing it will reject, okay, and until there is human intervention after review, whether that outlier is clinically significant, then that report cannot be released. Okay, so it gives you the opportunity to, okay, gives you the opportunity to be able to review whether the IQC has failed because of a significant error or not. Okay, and then the other recommendation in these clauses, you need to re-examine the sample. That is, if the rejection was appropriate, you need to re-examine the samples after the error has been corrected. Then the results from patient samples that were examined after the last successful IQC event, okay, shall be evaluated. What this software has assisted us in doing is we are able to check for any changes that happened for that particular test during the QC, because this is recorded on the action logs on the Unity real time, whether it is a reagent change, calibration, or a major service. And these are some of the things now you look into. If I'm going up to when am I going to repeat the samples? Okay, maybe I'm running 100 samples in an hour. I've changed a reagent after 2 hours. Okay, then I have a shift. Do I need to repeat all those tests for the previous one? So you need to consider up to what time. You can sometimes it's not economical, okay, to everybody to run the samples for the previous day, all of them, up to, because if you run your samples in the morning, okay, so you need to devise a mechanism on how am I going to review my test backwards, so that I am able to ensure that I'm not overdoing the quality controls. Okay, okay. so sorry for that. So on the last part is the other requirements which require IQC data collection, analysis, review, approval, and storage. So we have several clauses here that include clause 6.4.3 on equipment acceptance procedure, whereby lab shall verify that the equipment conforms to specified acceptability criteria before being placed or returned into use. Okay, so if you're having a system where you are recording QC, okay, you are able to enter this QC, the IQC data into that system and check whether the acceptability criteria has been met or not. Okay, also on reagent and consumables acceptance testing, which we commonly call lot-to-lot verification. Okay, you can use your IQC to check lot-to-lot verification. Okay, I've changed a lot 5 minutes ago. I ran QC. I have the IQC data for the previous lot, so I can be able to compare If I've set my rules appropriately in the system, if it does not fail, I know the acceptability has been met. Okay. Then on verification of examination methods. Okay. So when doing verification, issues to do with precision, you can be able to record this data on the software, and it can be able to calculate for you the coefficient of variation, and you compare this with the manufacturer specifications on acceptability, okay, and see whether your precision has passed or not. On measurement of uncertainty, okay, whereby you need to review your measurement of uncertainty at specified intervals, and also this has to be documented, okay. So like you've seen, the Unity real-time has really assisted us in calculating the measurement of uncertainty, whether you are using standard expanded measurement uncertainty, or we are using together with your EQA provider. All these is available to measure the measurement uncertainty. Then on EQA, whereby there is a recommendation that when an EQA program is either not available or not considered suitable, the laboratory shall use alternative methodologies to monitor. Okay. And one of the alternative methodologies is peer review. Okay. If you're using third-party controls, okay, and you're using a software that can transmit data to third-party provider and give you a report, then it becomes very easy for you to be able to fulfill this in cases where you don't have EQA provider in your area. So with this, I think we are done with the slides, and thank you very much.
Thank you very much, Mr. Arnold, for that wonderful presentation. I'm very sure that you have been speaking to very many participants here who have had to grapple with doing manual LJs on monthly basis on Excel spreadsheet. Probably there is a lot of answers in your presentation, but we want you to respond to a few questions that have already been asked and others that may be coming through. Please, participant, keep your questions coming on the chat so that the presenter can be able to respond to them. We taking a poll also? The poll is running. Please also do participate in our poll. Okay, very good. So a number of questions have been asked here that we need the presenter to respond to. The first question is, can a lab use 3SD to accept the IQC results in if recommended by the equipment provider? The second one, I think you just respond to that one first.
Okay. As per the ISO 15189, okay. Basically, the quality control is risk-based. Okay. So you need to ensure that you can use a 3SD. Okay. But are you mapping it? What is your coefficient of variation that you're using to map your 3SD rule? Okay. And basically, if you're using most of the equipment manufacturer and providers give you a range of 3SD, okay, the manufacturer range. But then you need to establish your own lab mean and SD, okay. So if your SD is too narrow, the SD will you are setting your rule is 3SD, you can narrow your SD, okay, so that you can be able to cover the appropriate coefficient of variation.
Okay, very good. Many questions coming your way. Another question, that's number 2. Supposing you're using plus minus 2SD in every 100 tests, how many QCs do we expect to fail? I think this one here is asking about the probability of distribution of the QC
Yes.
on your LJ charts. Yeah.
So basically, we want 95% to be in, okay? So 95 of them should be in. But that does not mean that the other 5%, the other 5% of the outliers are actually QC failures, okay? This could happen due to some changes. That's why we are saying you need to monitor your changes in calibrators, calibrator lot, okay, calibrations, equipment maintenance, and reagent changes. So that the most important thing is for you to establish why there is a certain outlier, okay, and whether it is within the whether that is clinically significant. Remember, your 2ST could be too narrow, okay, and you will be getting a lot of outliers. So when you are reviewing these and setting your evaluation criteria, you need to have the clinical significance in your mind.
Okay, very good for that response, Arnold. It is important for them to know that it is not okay to leave the ones that are not falling within the expected distribution. They still have to do something about them. Another question, there are those using symmetry, dry chemistry, for example, and it's very expensive to do QC. Maybe I can leave that one and talk about later. Could you please explain what type of EQA for glucometer? I think that was Jackie's question, or you can have a go at it.
Do you want to pick that?
Yeah.
Now,
yeah,
there are several EQA programs for glucose meters, and I want to sensitize us that we will be rolling out a POCT course in collaboration with Global Health, Workforce Program, and Royal College of Pathologists, and in partnership for Global Health. So this will really help, and I want to encourage all of us to join once it comes out. But EQA for blood glucose, POCT, point of care testing, I'm assuming when you're using the glucose meter for point of care testing, first of all, the manufacturer or the vendor must have provided you with IQC. And that IQC is what you use when you're dealing with a bigger aspect of point of care testing, where the clinical team are the ones who are testing, is a bit different. Not necessarily to change what the manufacturer has said, but you use what the manufacturer has given you. In the event the manufacturer does not have IQC, you source around. The providers are available that have given IQC for specific glucose meters. But just ensure that you are running IQC for all the glucose that you're doing. Lest you give a patient a report of a glucose of 50 and they're not diabetic. Over to you.
Okay, thank you, Jackie. I also want you to respond while you're still there. Please respond to this one. They are asking, how do you perform QC in parasitology? You can just quickly mention that in passing, and then you can go back to Arnold.
So I want to give specific example for parasites like malaria. And I had mentioned in my slides that you can use previous patient samples. Most of the time, you'll either use certified material or not have those certified materials. But if you find you want to do a positive control, for example, you have received a malaria that is positive, you will keep that sample and you can't keep it for too long. Again, what we sometimes do here, I'll give you a specific example is, and I know my team is online, and if I miss hematology, correct me. So when they remove, they will get a positive sample. They will keep that sample for 24 hours and then change it again, because people who live in Kisumu are more fortunate because they'll have malaria always. As we may not have the malaria positive samples always. So when you're doing, let's say, for example, depending on the test procedure that you're using, maybe you're using QBC. QBC, that specimen may not remain viable for too long. So we'll use the previous sample, change it within 24 hours for another sample. For positive sample, you just want to identify if malaria looks like this, my patient also should look like this. When you're dealing with slides, let's say you're now doing PBF, you will have to keep some of those positive samples to use them as QC. Because when you're doing your specimen identification, like let's say, not really specimen, but the species identification, there are people who may not really differentiate what is ovale, how does ovale look like, how does these other ones look like. When you are QCing your parasites, you may not necessarily be QCing the presence or absence. You're also QCing your staining. So you want to see if your staining is appropriate, and that is why you need to really not do it pre. The staining has to go with the ones that you're staining on that day. So you're also checking if your staining is appropriate. If it's not appearing on your QC, then you change the stain and do another stain. That also applies for special stains. Over to you.
Okay, Jackie, the last one. Maybe I want to have your take on this question. I was tempted to respond to it, but it's fine. You can just give us your take. There is a person who has asked about the dry chemistry, and he has given an example, I think, analyzer called Siamati or something like that, for dry chemistry. And they say the QC is very expensive, but the manufacturer argues that or purports that the system has got AI or artificial intelligence to do its QC. Now, yes, maybe what is your take on this? Is AI now going to replace IQC?
I want you to know that the world is moving. This person who has asked, the world is moving into artificial intelligence, and we agree. But we have not reached where AI is replacing our quality control. And I think when we reach there, then we will really be there to experience all this. Quality control is never replaced by artificial intelligence, because artificial intelligence will not tell you. It will tell you very many other things, but for now, we know that the manufacturer has told us that ABCD needs to be done. If you change how you are doing this as per the manufacturer, then there's something we call IQCP, Individualized Quality Control Plan. Because of the expensiveness, you don't need to really struggle, but it doesn't apply to every test. For example, it doesn't apply for histology surgical specimens. What you do in this case is you exempt yourself from doing, and I need you guys to get me correctly, you exempt yourself from running IQC on daily basis. You don't just wake up and say, I have stopped doing IQC on daily basis. So what you do with IQCP is a very planned process. You do a risk assessment, but you have to analyze your IQC for a certain period of time, review that IQC, and there should be no failure. Look at your personnel and competency, and all processes should be constant. I know what I mean by that. That once one of these things that you have evaluated before has changed, then you still need to have to go to your IQCP and review it again. So after you have put this in place, you can be allowed not to be running IQC on daily basis. Some of the cases we have implemented this is MTB, where consistently our IQC has passed. And so what we are trying to tell an auditor is, even if we run this IQC, it will still pass. So we are saving on our cost. So you give your risk assessment, you give your personal evidence of personnel training and competency, and then the evidence that you have done this IQC over a period of time and there was no failure. IQC saves you instead of basing on AI. Vendors will confuse you with some of the marketing skills that they have. So please don't listen to them. Follow the standard and the regulations that we follow, including CLIA.
Thank you, Jackie, for stating that there are standards and regulations to be followed. So sometimes manufacturers' work may not be enough to be relied upon. So another thing that we need to know that technology is supposed to aid. Yeah, it is supposed to interface with, for example, in our case, technology should make your QC easier, interpretation, presentation, all that. Artificial intelligence, I believe, is not coming to replace your IQC, but rather augment and make the IQC more efficient. But like the speaker has said, the world is changing and where things are changing very fast. We'll get to see that when that time comes. Now, the other, maybe we can just ask Arnold to respond to one or two questions, then we go to the next speaker because our time is also running out. And maybe he needs to, much of QC has been dealt with. Maybe he can tell us something a little to do with the question about measurement uncertainty, where somebody says, please explain and give examples of measurement uncertainty. You will briefly respond to that. And secondly, you will tell us if we have total allowable errors for HIV combo, hepatitis B, and syphilis tests. I guess this person is assuming those are being qualitative tests. So maybe you can just respond to those two questions and then we can go to the next speaker and then we'll come back to you to respond to the next.
Okay, so Robert, on measurement uncertainty, can you come again?
The speaker asked, please explain and give examples of measurement uncertainty. I think you just explained the concept of measurement uncertainty. From there, the participants will get to understand what examples can be. I think you just need to explain the concept and give the relation to the quantitative test, and then from there, I'm very sure the speaker will understand the rest of the examples that we're asking about.
Okay. So thank you for that question. So basically, measurement uncertainty will be applied only to two categories of tests. That is quantitative tests, okay, which are most of the clinical chemistry, hematology tests. And any test that is reported qualitatively but has a quantitative component, okay? If your analyzer is measuring in maybe absorbance, okay, and giving you results in absorbance, you need to establish the measurement uncertainty for those particular analyzers. But for qualitative tests, all you do is you check for the measurement uncertainty is determined through the pre-examination and post-examination phases, okay? What factors that can be able to influence the uncertainty of reporting those particular tests. But there is no quantitative measurement that will be given in that particular aspect.
Okay. The next question, the very last one I want you to respond to now was what is the do we have total allowable error for HIV combo and hepatitis B and syphilis? So I don't know whether this is a qualitative or quantitative test, but I think I was asking in relation for them being qualitative tests.
Okay, so this one is a bit dicey, okay, because the total allowable error, yes, will be there for where does your absorbance begin from, okay? And the good thing when you're having peer reporting, the positive cases like for HIV, okay, you will be able to establish within your peer, okay, and you will be able to establish within your peer how your variation is on that particular test. But the main significance, since you are reporting on a qualitative basis, you don't need to have a total allowable error for this.
Very good.
So,
Thank you.
Robert, let me just maybe add something about that. assuming that this person was talking about viral load, because HIV can be quantitative, viral load, and I want to encourage them. Just as I mentioned, if you go to WestGuard and you're not able to get the total allowable error, then you can do data innovations. It can also give you the total allowable error for specific tests. You can be asking for HIV and maybe you have other tests that you can't do. Like, for example, the WestGuard does not have D-dimers. So you can do to that, go to data innovations and just find out how that is all acceptable.
Very good, Jackie. Data innovations. Okay, so data innovations is another resource where they can find information about total allowable error, just like in WestGuard. So what we are getting here is that if you cannot get one from one resource, you can go to a different resource. I think that is important for us to know that. Thank you very much, Jackie. Now we switch gears and move to our the last presenter for today's session. His name is Nikolai Gushchin. He is a regional marketing manager for East Europe and Middle East Africa for Bio-Rad. And I hope I said that right. So unfortunately, I didn't get to see your bio sketch, but you can tell us a little about your bio. He was going to talk to us about, he will give us a brief overview of the Bio-Rad QC solution, of course, in line with the requirements of ISO 15189, as has already been presented by the previous speakers. Also, a summary writes the benefits of Bio-Rad QC control solutions and how to implement such solution in our settings. Karibu sana, you can take over. Thank you.
Okay, thank you very much, Robert, for this introduction. By the way, can you hear me well? Can you hear me?
Yes.
Okay,
yes, we can hear you.
Okay, hello everyone. Good afternoon. So my name is Nikolai Gushchin. Just let me share the screen and the presentation slides, and we'll start. Okay. Can you see the slides? Okay, I hope you see it.
We can see the slides.
Oh, okay, great. Thank you very much. So the name of my presentation is the ISO 15189 QC requirements and the Bio-Rad solution. So in this presentation, I would like to focus on the on the Bio-Rad solutions and how they can help you with the QC requirements fulfillment from this standard, from ISO 15189. So let's start with a general question: why we do run quality controls? And these are the answers: to measure the precision, to measure trueness, to verify the calibration, because sometimes our test system fails. And we also have some requirements, like, for example, in the inserts from the manufacturers or in a standard, like 15189, for example. So the answer is yes, we need quality control for all these reasons. But the main reason is that we need to validate the reliability of the patient results. So because at the end, this is what laboratory produce for the patients, for the physicians, and it's very important for the patient life. And we have requirements. So I will not read this because we already we've seen these requirements from the previous presentation of Dr. Jackline and Dr. Arnold. So let me tell you about the two conditions. So what we need to validate the reliability of the patient results. So of course, we need to have a good QC material. So what does it mean, good QC material? We will have a look in further slides. And we need to use it in the right way. And of course, we have a huge array of the data, of the QC data that we need to process, that we need to analyze and to make the correct decisions. So definitely we need something for the automation. So we need we need a comprehensive software that will help us to manage the data. And both of these things, both of these tools things, they are mentioned in ISO. So we have a list of the requirements, and I prepared this list of the QC requirements where Bio-Rad can help you. So let's go have a look at each requirement in a little bit more details, and what solution from Bio-Rad can help you to fulfill this requirement. So first of all, about the QC material. So we know that we have requirement about the matrix should be as close as possible to the patient sample. So of course we're measuring human patient samples, and quality control material should be made of the same matrix. So in the best scenario, because this material, the human serum or other material, human material matrix will behave in analysis in the same way. So we can be sure in these results. And we need to be very cautious with the quality controls, which can be made on the animal base, on animal blood components, or completely from some chemicals, because definitely we will have some discrepancies in the analysis, some matrix effects, and this results will be not so reliable. So this is why we have this requirement in ISO. Second thing is that about the concentrations, the concentration for this quality controls. They must be clinically relevant. And what can I say about the Bio-Rad controls is we always designing our controls from R&D part to make several levels. For the most of the controls we have 3 levels. For some of the controls we even have more levels, like shown this here in the example. And of course to make it clinically relevant. So I just want to show you the example of our recently released control, which is called cardiac advanced control. It has 4 levels, and this 4 levels concentration is designed according to the latest ACC and IFCC guidelines, and we have very low concentrations, close to limit of detection, below the 99th percentile of the population, and more higher concentrations, like normal and high concentrations. Another important thing that ISO telling us that we need to consider a third-party QC, either as an alternative to or in addition to the quality control material supplied by the reagent manufacturer. So this is not only ISO. There are a lot of other standards, national guidelines of different countries or international, like CLSI, also having similar statements, similar requirements about the use of third-party QC materials. So it makes sense because independent QC, they are versatile, they are produced in independent way from the reagent, from the instrument, and this is why they can give you the best estimation tool of how your test system performs. I also want to show you highlight the long-term quality control monitoring statement, which is mentioned in ISO. So it's saying that detection, the procedure should also allow the detection of either lot-to-lot, reagent, or calibration variation, or both. So to fulfill this requirement, we need some control material with quite a long shelf life. So like it's shown here on this diagram, on this chart. So we have this independent control with a shelf life, for example, 3 years. And during this period, there can be some changes in other components of your test system, like it can be changes in the reagent lot or changes in the lot of the calibrator. But the shelf life of the control material overlap all these other component shelf lives. And this can give you the understanding what is going on in your test system, what is going on with the results. Every time you have this change in the reagent or calibrator or some other component or diluent, for example. Okay, and this is just an example why it's important to have a quality control material like Bio-Rad proposed, for example, with the long shelf life. This is an example of the data collected in Unity report for Abbott instruments, and we can see here for 25-hydroxyvitamin D, 2 peer groups. One peer group on the top and the one on the bottom. The only difference here between 2 peer groups is that they were using a different calibrator with the different reference numbers. So you see this reference mentioned 3L52, and for the second peer group, another reference. And just have a look how the numbers are different. For example, for level 1, in one group we have 12, in the second group 7. For level 2, 22 and 13. And level 3, 56 and 33 in the second one. And later, when laboratory was investigating this case, they got a notification letter from the manufacturer, from Abbott, also telling, providing some more information about the calibrators. And actually, the difference between them was that the new calibrator 5P02 was standardized against the National Institute Standards material. So this is why we have this quite a big difference in the performance of the test system. So sometimes this information comes to the lab quite late. Sometimes it can be unnoticed from the manufacturer. So definitely we need some tool, some quality control material with a long shelf life, and also with the interlaboratory comparison that will allow us to track, to notice, to catch this change in the values, because you see that this change is very significant. And of course, it will be also reflected in the patient results. Yeah, we already spoke about the selection criteria for the good QC materials with Dr. Jackline. I just, some of them already repeated, but what I want to add here is that it's also very nice to have a versatile quality control material. I mean that control that can be used on any brand of the instrument, on any reagents, and also to have this quality control material with a lot of analytes, so multi-analyte composition. It's also give you a convenience of use. And also to mention that if the manufacturer of the QC material can propose you the reliable interlaboratory data, it's also very nice. So we have, as we already spoke, we have Unity in the laboratory comparison in Bio-Rad, and it's a very reliable source of the information for your external comparison of the data, external evaluation, and for your daily troubleshooting. And of course, nice to have a wide portfolio of QC products from one vendor, because one vendor can give you even more in terms of the education, technical support, and so on. And Bio-Rad can propose you a very wide portfolio of products covering 500 plus analytes, and we have more than 300 quality control products. So everything what is needed for the clinical lab and even more. We have also the external quality assessment, and we can propose you several options of the vials configuration, vials or tubes or compact vials. So depending on your need and depending on the brand of the instrument you are using. So this is first requirement, and we can tick this requirement, make a checkbox. So this is fulfilled. Second thing is the compare result with other laboratories. So external quality assessment, and ISO telling us that we have several options for the external quality. And Bio-Rad can propose you 2 options for the interlaboratory comparison. First of all, we have I would say, classic external quality assessment programs, which is called ECAS. And we also can propose you the interlaboratory comparison in Unity. Unity software, when the interlaboratory comparison is based on the data which you are collecting in your internal QC, in your daily QC with your internal controls. So just a little bit telling about the differences between these two external or interlaboratory programs. So in ECOS, in classic programs, a QA program, you're measuring samples, specific samples from time to time. Like frequency can be, for example, once a month or once a quarter. In Bio-Rad ECOS, it's one per month. And you have a snapshot of your test system performance at a specific time t. So it's retrospective analysis. So you always have the report with some delay, a little bit later, like 3 days later, for example. And this is evaluation of the accuracy. So in Unity program, you have much more data because you have the data from all your daily QC, all your daily measurements from every day. And this gives you the ongoing performance monitoring. And this is called evaluation of the trueness or bias. The benefit of this program is that you always have much more data, and you can reach this data, and you can get this data anytime when you need it. So just a little bit about the ECOS programs. Usually, so most of our programs, they consist of the 12 samples. And together with the samples, we provide reports, the statistical evaluation of each sample. So this is the slide showing our portfolio of AQA programs. So again, everything what is needed for the clinical lab. Just a little bit about the participation numbers. So we have 110 participating countries and more than 30,000 participants in the program. So that means that we have a big peer groups, we have a lot of participants, and the statistics of this comparison is reliable. All our programs, AQA programs, they are accredited according to the special standard, which is 17043. And this is, by the way, also a requirement from ISO. And we have this special certificate showing that all our programs are accredited. All participants enrolled to the ECOS programs, they will receive the certificates, different certificates. First of all, certificates of registration. And also at the end of the cycle, you can receive a certificate of achievement. And of course, every month you will receive a set of the sample reports with a comprehensive statistical analysis of your data, with comparing your results with the worldwide data collecting from other participants. Second choice, second option for the interlaboratory comparison it's mentioned in ISO. For example, it's saying that it can be based on the examination of IQC material. So this is exactly the case for the Unity. So in Unity, we have a module for internal quality control, and at the same time, this data can be sent for the comparison, for the interlaboratory comparison. Just a little bit also about the participation numbers. So we can say that Unity program at the moment is the largest peer program in the world. We have 38,000 participating labs, thousands of instruments, as you can see here, and millions of QC results processed monthly. So it gives you a very big peer groups and very reliable results. And because, as I mentioned, in Unity you have instant access to the data for the comparison, and so the Unity is actually, it's a complementary program to classic AQA programs because it can give you the help to identify trends or shifts that may occur between proficiency testing service or classic QAs. And of course, you will get also comprehensive reports. The format of the reports is a little bit different, but they are also very useful. So this is regarding the external quality assessment. So next thing is to perform internal quality control. And for all these statements, statistical techniques, acceptability criteria, preventing the release of the patient results which are in out of control condition. So with all these things, Unity real-time or Unity solution will help you. So we have all necessary functionality in the program to track the results, to analyze them, and to make the right decisions. So we already seen this bench and supervisor data review with all the basic statistics which is needed, Westgard rules, Levy-Jennings charts, and so on. So I just want to quickly show you that we also have here the in this report you can see the colors. The colors means that we have a QC warning, for example, and we can see the rules which were triggered with this warning. Red color means that we have a QC rejection, and white, this is for the normal QC data. So we also have here the columns with the action and comment, and if we did some troubleshooting or something happened in the lab, which some event that can affect the results, so we can also add this information to the program, to the software. And for this, we have a special library of different events or action. This is called actions, and we can select this action, and this information will be linked to the specific date and to the specific result. And this information is very convenient to analyze when you have a out of control and you're trying to understand what is the reason, what is the source of the issue, and it will help you to understand this, to understand the source of error. Other thing is available in Unity is that you can also track the reagent load information, reagent bottle information, even this, if it's in use or standby for the new and big instruments. So this thing is available. You can also track calibrated load, and you can also the type in the program calibration date and time. So it gives you also the additional information about your system, and it will help you to troubleshoot. And of course, we have a variety of charts, Levy-Jennings charts, multi-Levy-Jennings charts, when we can combine the data from different levels or different analytes and see the picture. Bar charts, this is also very convenient, can be used to evaluate the data for the long period, for several months, for example, and to see some trends. We have more comprehensive analysis like a UNT chart. So this is also combined with the inter-laboratory data here. Qualitative bar charts for the qualitative tests. And just to show you the example how this can be used, I want to show you the real lab case, which were published in the article. So what we have here, we have two Levy-Jennings charts for the 3 glycerides. This chart on the top showing us the level 1 and level 2 for the 3 glycerides. And the Levy-Jennings charts on the bottom showing us the electrical conductivity of the water source, which were used for this instrument. And they also did this, the lab also recorded all events, what was happening in the lab, like water filter maintenance, instrument maintenance, and so on. But what happened actually in the lab? So there was everything is all right with the instrument, but at one point of time, when they did the maintenance in the water source, in the water filter, they noticed that their results start to go down. So we start to have this negative trend of the data. So what they did, they made the multi-levigening chart with 2 levels and also with the water conductivity, and they noticed that there was an issue with the water source. So the conductivity grows up. So it means that some impurities appears in the water, some pollution. And when this water came to the instrument, the results go down. So because of this bad water source, results go down. So the instrument was also contaminated with this bad water source. So first of all, they changed the water filter. They did the maintenance for the water filter, but this didn't help with the instrument results. So they decided to stop testing on this instrument, and they decided to do the instrument maintenance, half-year maintenance. And after that, the results came to the normal. Came to the normal, and they continue patient testing. So this is just an example to show how the multi-levigening charts together with the action and comments can give you a clear picture of what is going on in a lab, quickly troubleshoot this situation, and to have the full traceability. Because, for example, if the audit came in the lab and find out this shift on the levigening chart and ask you what happened, you will be able to explain the situation with all this additional information very quickly. Okay, next thing is ensure the traceability of the QC results. So just very quickly, that ISO always telling us that we need to keep records of everything, of non-conforming work, actions, changes for the reagents and consumables. And as we've already seen with the action and comments, with the different special columns for the calibrators, for the bottles in use and so on, we can track all this information. And also we have special reports, data review report and audit trail report, which can help you also with to collect this data and to track all the information. Other thing which we have in the software is the ability that you can establish analytical goals. So let's have a look. What is this? Well, first of all, ISO telling us that if we have out of control condition, if we have a QC failure, like for example, 13S will trigger it. So we are in kind of a tricky situation. So that means that our previous results are also on the question mark, because when the problem happened with our test system, we don't know. It can be like in the middle of this time period, or it can be right after this QC. So ISO telling us that we need to re-examine samples, but in some situation it's very complicated for the lab. Because it can be very expensive. Like for example, if it's an immunoassay test, it can be really expensive, and it's also quite hard to do this if already patient results released to the patients or to the physicians. So what we can do in this situation, we can use analytical goals range. Let's have a look on this situation. This is the regular statistics, regular levigening chart. And at one point, we, in a lab, for example, we in a lab changed the reagent load. And after change of the reagent load, they had this shift in the QC data with the same lot of QC material, of course. So, and they are trying to understand how this shift will affect patient samples, and if it's acceptable or not. Unfortunately, the regular statistic analysis, levigening charts, and the Westgate rules not taking into consideration the clinical relevance. of the shift or some analytical error. To make this estimation, we need to plot our chart with another allowable limit. This allowable limit, which is called analytical goals, can be based on the total allowable error, for example, on the biological variation data. So in this case, when we plot this total allowable error for the same data, as you can see this shift here, we can have a look and we can estimate our results if they are still within the total allowable error or not, even with this analytical error shift. So in this situation, we see that specifically for this analyte, we're still within the total allowable error limit. It means that biological variation of this analyte is much, much higher comparing to this analytical error shift. And there will be no impact on the results, patient results interpretation, and there is no need to retest patient samples. So this is the example. This is the infographic showing us the different models from the Milan conference hierarchy. There can be model 1, 2, and 3. The most used one usually is the model 2, based on the biological variation. And this information is already included in the Unity real-time software. So we have a contract between Bio-Rad and the EFLM organization for the use of this biological variation database. So as you can see, this is the window for the analytical goals, and everything is already included. All the information is included in the software. So what you need to do is to tick these checkboxes for the analytes which you want to monitor for the total allowable error based on biological variation. And this is how it looks like in Unity real time. So this is the regular Levy-Jenny charts, your regular statistics. So it means lab mean plus minus 3 standard deviation. And when you click this AG checkbox, which means analytical goals, now we have another limit on this chart, which is target plus minus a total allowable error. And we can see the same data, but with another allowable limits. Okay. Just a little bit about the measurement uncertainty. So just to show you that how it can be calculated in the software. So we have 3 most used formulas for the standard expanded uncertainty. The most simple one is D, just multiply by 2. And we also have the formula which takes into account the interlaboratory bias. So we have the components here for the imprecision, and we have a components for the trueness. And the third mostly used formula is formula with the calibration uncertainty. So this is the value of the calibration uncertainty, and this information can be taken from the manufacturer insert. So usually they mention what is the uncertainty of the calibrator, and this information also can be used for the calculations. And this is the report, how it looks like in the software. What is important that you can also compare your calculated measurement of uncertainty with the total allowable error based on different standards or biological variation and so on. So we have a big list of different standards, starting from the BV, which is biological variation, CLIA from US, different European national standards, from Australia, from Germany, Turkey, China. You see a lot of other countries and standards and so on. And for these reports, you can also generate the PDF form and save it and print and show it for the audit. Another important thing mentioned in ISO This is the continuous education for the staff, training and education. So we have the statements about this. And Bio-Rad also can help you with this. We have a lot of educational materials for the QC. We have educational QC YouTube channel with a lot of videos starting from very basic of the QC up to more advanced topic. We have also different articles, education brochures, workbook series on our portal, which is dedicated to quality control products and quality control itself, which is called qcnet.com. So it's a very useful resource. I recommend it to everyone. And all these materials, they are free of charge for everyone. Bio-Rad also organized a lot of seminars and webinars. We also invite QC experts from different laboratories to share the experience. And of course, we have this software, very comprehensive software, Unity Real Time 2. And of course, for all the users of Unity Real Time software, we provide a complete training on starting from fundamentals up to more advanced tasks, wasteguard advisor, analytical goals, measurement uncertainty, and so on and so on. So for all the functionalities and all the modules in the software. And the last thing I would like to mention here is the access the risk for the patients. So in new version of ISO from 2022, there are a lot of statements about the risk management. So it's mentioned almost everywhere in every chapter. Like for example, this one shall establish, implement, and maintain processes for identifying risk of harm for the patients, and so on and so on. So how we can help you with this? We have a special software module, a special license. We provide a license for this software, which is called Bio-Rad Mission Control. And this software can help you to determine the laboratory risk management index, evaluate the test method performance based on your QC result. You will know your current risk of reporting incorrect patient results, and what is also more important and more practical, you can select rules and frequency to lower the risk and to fit your lab risk tolerance. So just a quick example also to show you the screenshot from this software. So you have the list of all your analytes, all your instruments. You can run the evaluation. This module it uses the data from the Unity Real Time. So first of all, you need to have the Unity Real Time, where all your data is collected together with the interlaboratory data, with the worldwide data, and based on all of this information, this module can make this sophisticated calculations can be done. So what we can see here is the QC frequency and the QC rule. So this software giving us an advice how we can improve, how we can reduce the risk for our patients. So for example, it says that currently we have one QC per day, QC frequency per day, but it needs to be increased twice per day. And for the QC rules, currently we use 1-3S rule, but better to use the repeat 1-2S. This will improve the situation. And the parameters for the risk management assessment, RMI, index of the risk management, and some other parameters, additional one. So just quickly overview to show you that we have all the solution. So as you can see, when you are deciding to implement ISO 15185 requirements or some other requirements like GCI requirements or CAP requirements, because in many QC requirements they are the same or very similar, Bio-Rad can help you to fulfill these requirements very easily. And I also want to mention in the conclusion that Bio-Rad is not just about the vials about the QC vials. So we have a complete QC ecosystem. So we have the largest portfolio of high quality QC solutions. We also have the best in industry software Unity real-time program with the best inter-laboratory participation with the highest numbers. And what is also very, very important in the quality control, we can help you. Bio-Rad can provide you a lot of services, which is extensive customer and technical support, because of course you will have a lot of questions. And the Bio-Rad teams, we have a dedicated teams only for the QC. They can help with all your questions, and of course we have a lot of sources for the customer education. Besides of this, we have also contracts and industry partnerships with all main big IVD manufacturers like Abbott, Roche, Siemens, Beckman Coulter, and so on. So this give you the benefits of the complete QC solution for a lab. So thank you very much for your attention. And what I also want to mention is that on this slide, you can see the QR code. So if you have, I already seen in chat that there was some question about the prices for the Unity and so on. So if you have prices, questions, or you want to get the catalog from Bio-Rad, or you want to have some speak with Bio-Rad about the demonstration of the whatever QC or external quality assessment or Unity. So please use this QR code and fill just very short form. Just let us know that you want something from us, and we'll get back to you with all necessary information. Okay, let me also send this link to the chat, so probably it will be easier for you to access the form. And yes, thank you very much again for your attention. And I'm ready to answer your questions.
Okay. Thank you very much, Mr. Nikolai, for that wonderful presentation. Indeed, you have already made us very much aware that IQC programs also provide peer comparison programs that can be used as an alternative to EQA as required by ISO 15189, and Bio-Rad is one of those programs that are available to be used by many participants around the globe. Thank you very much. Now, maybe we'll only take one question or two for Mr. Nikolai if they are there. But probably one of the things that I would want you to provide some more insight as we wait for any question is maybe you can highlight some pitfalls or challenges that are encountered by laboratories that are using manufacturers provided IQC, where the equipment is also from the manufacturer and the reagents and the calibrator. What are those pitfalls that would experienced by the lab that Bio-Rad is seeking to provide solutions for? Just a few words.
Yeah. Okay. Thank you very much. It's a very good question. So when we are speaking about the comparison about the instrument manufacturer controls and independent controls, so the first thing is about independence, independent assessment. So if you open the insert for for the manufacturer QC, so you will see the data for only specific reagent or only one instrument. So actually that means that this QC material is it can be optimized in a way to work with a good results with this specific test system. So it can be not so sensitive to catch the errors, to catch the issues with the test system. This is one thing. Another thing that instrument manufacturer controls, sometimes they can propose you less analytes. They can be mono-analyte controls or contain less analytes comparing to the independent, which are usually multi-analyte. And Bio-Rad controls we have, for example, for chemistry, one control, assay chemistry or multi-qual, which covers everything, all the routine tests for chemistry, or immunoassay plus control, which also covers everything what is needed for the routine immunoassay. And it's very convenient to use one control, one catalog item instead of the panel of numerous items from the instrument manufacturer. Other thing to mention, which I already mentioned in my presentation, about the shelf life. So usually shelf life of instrument manufacturer controls, they are somehow linked or tied with the reagent lot shelf life, which is usually 1 year. And this is quite a short period for the quality control materials. Again, as I mentioned, and as ISO requirements telling us that we need to capture lot to lot or calibrator changes, and for this we need a quality control material with a long shelf life, and this is exactly where the Bio-Rad can propose you this material with a long shelf life. What else? About, again, can be situation when the concentrations of the manufacturer controls, the levels of the manufacturer controls can be not very relevant, clinically relevant. Can be also can create some issues for the lab. You will not have the visibility of the important areas, clinically important areas of concentration. Well, I would say basically this is the main drawbacks of the instrument manufacturer QC.
Okay, thank you so much, Mr. Nikolai, for that presentation. Because in the interest of time, we may not take any more questions, and I believe that the previous presenters have already provided the answers for some of the questions from the chat. Thank you very much for your participation.
Thank you, everyone.
Okay, very good. From my end here, maybe I would just to highlight a few things from today's presentation, some take-home messages from this webinar. Number one, there will be, we have seen that more QC webinars will be organized, what needs to, and that will be communicated. I am also informed that the cost of the software, the URT software is very affordable, but F&S will liaise with the specific individuals that are interested in this so that they can be able to discuss more about the cost of the URT. Certificates will be provided for attendance. Very important to note that. Now, a few highlights from today's presentation. I just want to mention we have seen the importance of running QC. The first presenter also told us that the quality of the result is as good as the quality of the samples. We have also seen the importance of running QC. Without the QC, you have no confidence in the quality of patient results. That has come out very clearly. Another item is the real-time monitoring of QC, and we have seen this is one of the big features for the URT program that you have. It allows you to monitor real-time the QC, and you can see even from the standard ISO 15189, there is a requirement that QC should be reviewed in a time frame that reflects current performance. So I think that is a very good take-home message for our participants here. Of course, we have said with this kind of QC, it removes a lot of processes and efforts by technologies to monitor QC manually and have plot the charts manually. That party cases, of course, recommended by the standard ISO 15189. The last presenter has given us a lot of advantages for use of that party case and has highlighted a few pitfalls when people are just relying on the manufacturer's QC. And then we have also seen that that party QC, not only that party QC, but QC programs also have peer comparison programs that can be used as an alternative to EQA program when appropriate EQA program is not available. There was also a mention and highlight of other factors that may influence the QC outcomes from the last speaker. He has mentioned particularly distilled water. We have had, as assessors, we see a lot of problems with the QC, but the laboratories are not able to pinpoint the actual problem that is causing the issues. QC selections, we have seen it should cut across, the QC used by the lab should cut across the entire measurement range. Another speaker already talked about that. And this is also a problem that we have seen with some of the labs that are running a QC which does not provide the relevant challenges as required for the method. So we have also seen that what you do with your QC data determines the performance of your laboratory. And those are just a few highlights from today's session. And we hope that you will attend the next webinars that are going to be organized and communicated to you. I want to thank the participants. We have so many participants who attended today's webinar, and we are very grateful. And for them to provide the participation that you have seen, the questions, and some of the recommendations have come from our participants. And I'm very sure our presenters have also taken notes. We have had a few comments from the audience that were actually not questions, but they were also recommendations and suggestions. For example, Jared Muma told us on top of clauses mentioned by the presenters, the tools, this is the URT comes in handy when interpreting clause 7.3.1 of the standard on periodic evaluation of examination methods and also when calculating the sigma metrics, very important information. Another participant, Fanny Simiu, has also told us, has thanked the presenters for the wonderful presentations, and they are looking for future webinars from F&S. Vincent has also emphasized the importance of risk management or risk assessment in evaluation of QC. So those are very, very helpful comments from our participants. We thank you very much, and we encourage you to continue supporting F&S and attending our webinars that we shall be planning going forward. Allow me to thank all of you and hand over the meeting to Joyce, who is going to say the last thing before we can close the webinar. Thank you very much.
So thank you all. I think we have had a good session. And okay, I think my colleagues has something to say there.
Hi everyone, thank you so much for joining. Thank you for accepting our invitation. So for those of us who did not manage to register, we might not have your email address, so you can be able to share your certificate of attendance. Please indicate your email at the chat box and your organization. Again, the presentation will be shared in PDF form. So we'll have more QC webinars to follow. This is just our first one. And an important thing to note also, this year we are having Bio-Rad Africa Day, which normally happens every year. And this year it will be in Africa. And we are so privileged as Kenya because we have this Bio-Rad Day in Kenya hosted in Nairobi. So more details will come through. So thank you so much for your attendance and see you for the next. Bye.
Okay, so as we log out, there is a poll that we are currently running. Please feel free to just answer as you enjoy the rest of your afternoon. So thank you for joining, and we hope to see you in our next one. Thank you, guys.
Okay, sorry, before you leave, we are also planning to have courses which will help you upscale in your QC data management. Again, we will communicate about this. Please, in case you are interested with these courses, you can always reach out to us. Thank you.
Thanks.